It is a good house, Heidi. Yes, I do agree. It probably was, what does it say about the house? But power outage in Waterbury, really? From the wind? Okay. All right, 9:30. So we're going to start on time. A reminder that we're doing a review of the exam right after lecture. So if you can, it would benefit everybody to stay so we can review content from the exam. Okay. Um, I don't think I have anything else to talk about before we start. So, last semester we talked about safety and it's the same concept. And today we're going to talk about some of the focuses related to nursing and uh, national patient safety goals and QSIN and all of those kinds of things that help us be safer in our practice, safer for our clients, decrease incidence of injury, prolonged hospitalization, and all of those kinds of things. So here we go. Just a review from last semester, we talked about the culture of safety. We want to make sure that we're in a blame free environment so that everybody is comfortable or encouraged, empowered to talk about things that might be injurious to patients, staff, the universe, right? So, potential or actual meta errors, equipment that's not working, those kinds of things need to be reported so that they can be fixed. One of the frustrations for me is, and I'm sure you've seen on the clinical unit, or let me ask you, have you gone to a unit and there's like a little row of broken equipment? So, have they been reported? Those kinds of things. And sometimes they haven't been. Some hospitals have really good mechanisms in place where there's an official sticker that you put on a piece of equipment that's broken. What is the issue when maintenance or medical engineering was called, and then they can come and take it. And so there's checks and balances. Um, how many of you have found that there's a piece of equipment, it's broken, everybody knows that it's broken, but yet nothing was done about it? So yeah, and then how complicated is it for everybody to be able to do vital signs if the vital sign machine cart thing is broken? Because now you're down to two instead of three. It makes a big impact. So when you're on the unit, if you see things that are broken, see if you can find out what the routine is to get them fixed and recorded and all of that and back in service, and you'll look amazing. But it'll also help everybody with their workload, as well as not just broken, but things like that are injurious, like wiring is showing, or the wire came out of the cord. Those kinds of things are important. In a blame free environment, it's the organization and the employees. You want to make sure that the employees aren't penalized, those kinds of things. And we want anyone to be able to report an unsafe condition or behavior and to help find a solution. We talked last semester about there's been instances where somebody, I don't know who they are, but somebody in purchasing made a decision about a piece of equipment. And honestly, a lot of times it is economics, but they don't ask the end users. And nurses are the end users of the majority of the products that a hospital brings in. So use us and use us how we're using these um, pieces of equipment and whether or not they work for us and whether or not they're safe, right? And whether or not they're going to do, we have to think about time. We have to think about safety, risk of infection, injury to a client, those kinds of things. And we've seen a difference over the past couple of years that maybe the equipment, and I'm talking about like 4x4s or iodine swabs, as well as mechanical, electrical equipment, that somebody thought it was a good idea. But if we don't speak up and say, they're not meeting our needs, then we're going to be stuck with those. So the Joint Commission, which we've talked about a lot and we will continue to talk about, the Joint Commission had 2021 patient safety goals. And what they look at is the literature, they look at instances from hospitals, they look at sentinel events, things like incidents of infection, falls, those kinds of things. And they identified the national patient safety goals. And many of these we've talked about already. So identifying patients correctly, so you know about giving meds and the two identifiers and those kinds of things. Improving staff communication. So what information should be given in SBAR? How are we communicating? You've heard about bedside report, you've heard about taped report, and whether or not you're getting the information that you need from the offgoing nurse in order to safely care for your patient. They also looked at test results. So things like critical results. I remember when I was on a unit and I picked up the phone and it was a critical report. There was a lab value that was very abnormal and it was a priority for the lab to report it to the unit, and then it needed to be communicated to the provider because it was actionable. And so those are one of the things that you need to think about. If you happen to answer a phone on a unit and if it's a critical result, give that phone to a nurse so that they can do that chain of command, because they do look at and auditing. And one of the things that the Joint Commission looks at is what time was the result resulted? What time did the lab call? Who did they call? And they look at that chain of information of through to the provider and the actions to the client. We need to use medication safely, things like labeling medications. We've talked about that. Anytime you take anything out of an original container, be it medication, irrigation solution, etc., that it needs to be labeled. Care with anticoagulants. Big emphasis on educating our clients about anticoagulants, interactions with foods if those are possible, blood levels when they should be coming and monitoring and those kinds of things. Med reconciliation, about that, we need to have a list of medications that the patient comes in on, what they're on at the hospital, and then we need to have very clear instructions to the client for the medications that they're going home on. The other component that I want to add to that is, what are they supposed to do with the medications that they no longer need? And we need to talk to our patients about safety in medication disposal. And what I mean by that is they shouldn't be flushing them down the drain. We want to be careful that there's not accidental or intentional ingestion of medications. So safety away from children, safety away from diversion. So how can they get rid of their medications that they no longer need at home? There are pharmacies that have take back programs, so they'll take back the medications that they dispense. As well, many police departments, and I live in Wolcott, and in my police station, there's essentially a mailbox, but it's more secure than that you can get rid of medication and they're disposed of properly. And there's absolutely you walk in, you put them in. Nobody takes names, nobody does anything. And it's really helpful when you're cleaning out medications or have expired medications. And they do not have to be prescribed medications. It can be things as well over the counter. Education is very important for our clients about the medications, side effects, interactions, dosing, frequency, all the things that we need to make sure that information is written down, that they have reference. so that they know what the side effects might be, what to call. And we also need to talk to our patients about if they're not happy with the medication, say the side effects. That and if not to stop those medications without informing the prescriber. Big conversation about using alarms safely because there's things, they're very noisy. Are there so many alarms nobody knows what's alarming? Or there's so many alarms nobody's really paying attention to them. We need to prevent infection, hand hygiene, which we've talked about since September. We need to identify patient safety risks. And what kind of safety risks are we identifying with our or assessing for in our clients? Put that in the chat, please. Fall risk, easy lift. What else? Ooh, that was a pun. Easy lift. Mobility, skin integrity, allergies, med interactions, excellent. How about polypharmacy? So when we talk about the med reconciliation, it is a really good time to assess for polypharmacy. Also, whether or not dosage is correct. If a client is telling you that they're taking a specific medication and the dose is not appropriate or not within the what is the usual dose, you want to contact the provider to verify the dose. And it could be that, and we've seen it, a patient may take Lasix and take furosemide. They don't know that they're the same medication because they were taking furosemide and upon discharge, someone said to take Lasix. So they're taking both. Let me see. Aspiration precautions, absolutely. Older patients and reduced metabolism. And some of that has to do with, think about medication metabolism. So dosing may have to be tailored or tapered related to their metabolism. And not just their metabolism, but also think about renal function if it's a medication that is excreted in the urine. Okay. Infiltration, extravagation. Yep, absolutely. I can't say extravagation, whatever. Okay. Anyways, I need more coffee. Assessing clients for risk of suicide, and they're talking about in the emergency room as well as in behavioral health. So assessing clients, whether or not you're discharging them or admitting them. And there is a big I can't think of the word, problem that there may not be a treatment bed for a client that is suicidal. So now what do we do with the client? And you'll see sometimes that they're held in the ER, and sometimes it's for days until a bed is ready for the patient. Preventing mistakes in surgery. One of the videos that I've used in the past, and Waterbury Hospital had a focus on it. So we know right surgery, right patient, right place on the body, where they do timeout and they mark the site and all of that. But also things like fire in the operating room, because a lot of times in the operating room, they use cautery and they'll burn vessels and tissue and that kind of stuff. Well, if you have oxygen near a patient, and if you have flammable materials like drapes, a patient could be significantly harmed. Okay, so the 2021 goals continued about identifying patients correctly. So think about different settings where clients may not have ID bands, or think about a client that has dementia and may not be able to tell you their name and date of birth. And how are we going to identify them? Using meds safely, preventing residents from falling. We need to think about medications that can cause weakness, dizziness, or sleepy. Yes, the wristband, but we also have to have two identifiers. So we go with name and date of birth, but if a client can't tell you their name and date of birth, and using the wristband to combine the two and verify the two, how are we going to do that with a client that maybe is sleepy or has dementia or is unconscious? Okay, so we're going to get to that. So in 2022, they updated the National Patient Safety Goals, and some of them are going to be the same. But they've added some new ones. And I want to talk today about, in the clinical setting, how we're going to address these safety goals in the clinical setting. And it's not just, when you're on the floor, but it's also when we're providing treatment and services. So, in a variety of different settings that nurses and healthcare providers give care. And think about the newborn. Newborns are at higher risk because they can't speak. They have lack of distinguishable features. So the moms and the dads know that they're their babies. But it is very important that we make sure that the baby matches the mom and the support person, be it the dad or who it may be. When the baby is born, so the mom comes into the hospital, the mom has her bracelet with her name and date of birth on it. When the baby or babies are born, the baby has a bracelet on that has a specific number. So there's 4 bracelets. The baby gets 2, one on an arm, one on a leg, and the mom and the support person each get a bracelet. And that number is very specific to that baby. So all 4 bracelets have this number on it, kind of similar to where the barcode is in this picture here. And that bracelet is every time I assume care for the baby, when I return a baby or take a baby, I check those bracelets. And I check them with the mom or the support person. So when you come into a room to leave a baby, return a baby, if the mom and the support person aren't there, say the mom's in the bathroom, and you've got all the aunties and all the uncles that want to see this baby, you can't leave the baby until you've checked the bracelets. You want to make sure that you've got the right baby in the right room. And also consider a circumcision where we're doing a timeout and we need to make sure that we have the correct baby and all of those things. And the patient can't identify themselves. So we need to make sure that we're checking those bracelets and the consent and all of those kinds of things. In the NICU, and I'll say the nursery, also you want to make sure, for example, if the mom is expressing her breast milk, that it's properly identified. There's rules that each patient's breast milk goes in a bin, and let's face it, they use a bath bucket, but a bin, and only that mom's breast milk is in that bin. So each baby or mom have a bin of breast milk, and then that breast milk container, be it a bottle or those little Ziploc bags, are labeled, dated, and timed. Because in the NICU, they want to give the baby the breast milk in the order that it was obtained, because of the progression and the change in nutrition of breast milk. You want to mirror that for the baby. So they'll use I'll say oldest first, but again, and then 2 nurses need to verify that it's the right baby and the right breast milk. So the Joint Commission talks about acceptable identifiers. So the name, the assigned ID, phone number, or other specific identifiers. And what do you think that means? I love that they said that because it wasn't very helpful. But what other patient-specific identifiers or person-specific identifiers could we use? Put that in the chat. We're a little, maybe the last four of the social. Any other ideas? Yeah, Chanel, the photo. So if you look in Waterbury Hospital, when you pull up the client's MAR, in the top in the left, there's a picture of the client. So that can be helpful if you have a patient who has dementia or is unconscious or confused, etc. Okay, so that a photo can be very helpful in identifying. The Joint Commission also talks about labeling any specimens for blood or urine, those kinds of things, in the presence of the patient. So you want to make sure, when you go to collect that urine specimen, bring your sticker, put it on in presence of the patient, and that there's not a chance that you're going to put the wrong sticker on. Let me see. We talked about the baby. So when a baby is born, the baby gets the mom's last name, regardless of, and it's also baby boy. So it'll be baby boy Smith or baby girl Jones, etc. So it's regardless of if the parents have a name picked out for the baby and what the last name the baby may have. Because while the baby's in the hospital, we're not going to change names. So as soon as the baby's born, it's baby girl Smith. Okay. When the baby is discharged, the chart will change to the baby's given name. Can you imagine the chaos and confusion in the hospital if we started changing names in the midst of an admission? It really set up for error. And also consider if if the mom had twins. So it would be Smith, baby girl, A, B, hopefully not C or D, but okay. And also, you've probably seen on the hospital unit some type of communication tool among staff alerting if there's similar names, not just in the OB area, but on the regular patient floors for the grown-ups, right? So what have you seen as far as alerting staff with patients with similar names? Or have you seen that? I got one no. What did you see though, Anna? How did they do that? Bolded, I saw. Italicized and bolded. Red sticker and name alert on the chart. Not given to the same nurse. I've also seen on the patient board stars. Yep, there you go. Thank you, Sandy. So I've seen stars. So, and it's probably a variety of all of these things. So as many visual clues as we can have. And also, sorry, it has been discussed in report that there's patients with similar names. So people take caution with, what they're doing. Thank you. You had 3 of the same names on your floor at the same time. That's really kind of frightening. Okay, we have to be really, really careful. Okay, so we talked about critical results, and I don't think I really have much else to say about critical results, except that, it is evaluated. There is audits being done, and the hospital is required to have procedures for managing critical results of tests and diagnostic procedures. So when the Joint Commission comes to a hospital to visit, those are one of the things that they do, and they look at chart audits. Have any of you been in the hospital when the Joint Commission has come to visit? Oh, a couple of yeses. Okay. I'm kind of hearing that the Joint Commission has not been as active in their visiting since COVID, and I don't really have an answer for that, whether or not that's true and valid. Nurse Blake thinks it is, but we still have to, regardless of whether or not they're visiting, because they're really just I'm going to say a safety check that we're doing what we're supposed to be doing. So we shouldn't be doing things just because they're coming. They're assessing the period of time since um, they've last visited, whether or not we're doing what we're supposed to be doing. Okay, so let's move on. We talked about medications and labeling. So we need to label meds that, I don't know what I wrote here. Not labeled. What does that mean? If if things are out of the original container, it needs to be labeled, as well as all solutions. So things like irrigating solutions. So if you take even saline out of the original container and put it in one of those irrigating containers with the piston or whatever, what's in there? The next person needs to know. It also should be dated and timed because there's expiration periods, and it's going to vary. There's probably policies in the hospital for how long things can sit, but as well, there may be a different expiration shorter for something that has no preservatives or anything in it. We talked about anticoagulants, and also documentation of reconciliation and what education we're giving the clients. We talked about adherence to med dose and schedule. So especially for they were focusing on anticoagulants, but let's face it, it goes with every medication that clients need to adhere to the dose and schedule. So if a medication is supposed to be 8 hours apart, there's a difference between that than a medication that's given 3 times a day. Because you can kind of give those 6 hours apart, right? So what is the expectation of the client to be taking medications in the middle of the night or something like that? We need to make sure that the clients know about follow-up and lab testing if appropriate. And I'm sure you've seen the ads on TV for the new anticoagulants that are out there that don't require lab testing and may not have food interactions, which was a big complaint for some clients about whether or not they have to pay attention to food interactions. We need to make sure that they're aware of drug reactions. For OR patients, we need to make sure that they know when to hold meds and also when to restart them. So things like anticoagulants are usually held for, depending on the medication, a period of time before going to the OR or a dental procedure and those kinds of things. But also in the pre-op period, in the 1-day surgery, we need to talk to our patients about whether or not they're supposed to take medications that morning, right? Or whether or not they should have held them, etc. And also when to restart them. There needs to be protocols in the hospital for reversal of anticoagulants and management of bleeding events. Looking at those lab tests to monitor the anticoagulants. And heparin, an anticoagulant used in the hospital, IV, they're saying it should only be infused on an IV pump. So clearly there were issues somewhere where now they're making these recommendations, and they're really not recommendations, they're rules. They're focusing again on med reconciliation, and looking at how we're communicating that with our client. Again, what meds they're going home on, when they should be restarting them, and looking at the dosages. And reminding or telling patients about what the purpose of medications, that each medication is. And we do that. I see you do that in clinical. So again, labeling. So we need to label if we're taking a medication. Let me see. Heparin. Heparin should be on an infusion pump. So if we're taking a medication out of the original container, the label should have the medication name, the strength, if we've diluted it. So if you've put Normal saline to dilute ampicillin powder, that needs to be there. And the volume. The expiration date, if it's not going to be used within 24 hours, or the expiration time if it occurs within 24 hours. So an expiration date and time is good. Don't get too caught up in that. The other thing is, especially in the OR, the Joint Commission was talking about that so I am sure we have told you that you never give a medication that is drawn up by somebody else, right? Tell me yes. Okay. Thank you, thank you, thank you. Okay. So you're never giving a medication drawn up by somebody else. Somebody gives you a syringe, no thank you. I'll go get my own. All right. And everybody knows that rule. Hey, every once in a while, somehow it comes up again. But in the OR, it's possible that somebody drew up medications and it's going to be given during the case. So, what the Joint Commission says is that both people need to be there for the preparation of the med and the labeling of the medication, and that's acceptable. Okay. Okay. So, alarms. Big concern about alarm fatigue. Too much going on, too much beeping, and people ignoring them. So they're really looking at what alarms are necessary, what settings should be used. They're also looking for policies to see who and when can the alarms be disabled. So who has the authority to disable an alarm and also change parameters. They're looking at the detectability. Can you hear the alarm? Or is it something that is Wi-Fi to the nurse's station, like cardiac arrhythmias, right? And then monitoring and responding to the alarms. There's so many. The first thing I think about is fall alarms, and if a patient's gotten out of bed, what you're hearing, and or I'm going to say it anyways, that if you hear an alarm that we're responding to it, and if it's a bed alarm that maybe a patient shouldn't be getting out of bed, that you're going to be with the patient and you're going to wait there until someone who knows the patient can come and care for the patient, but you're going to respond to ensure the patient's safety, right?
Right.
Thank you. Okay, make me feel better. But alarm fatigue is, I mean, how many of you, I'm asked, how many of you hear pump alarms in your sleep? Because I do. Maybe you haven't been in the hospital long enough, but I do. All right. I am not going to spend I don't want to spend any time about hand washing, but hand washing and preventing infection is key in the Joint Commission. And they're looking at things like hand washing and James, you're going in timeout. Hand washing, and they will do things like stand in the hallway with a clipboard and watch you leave a room and to see whether or not you've washed your hands. They do that. And I know Dr. Sims at St. Mary's has done that. And I know that he's the infection control doctor. And I know that there's people at Waterbury Hospital that have monitored that as well. But also think about the things that we've talked about since you've been with us. Things like sterile technique when we're putting in the Foley catheter, because CAUTI's catheter-associated infection is incredibly important, and that is something that can be easily monitored. Patient has a UTI, did they have a Foley, right? Catheter care is critical. Things like we've talked to you about with a sterile field and where things can go and those kinds of things. Those are all related to preventing infection. Okay, I'm done with talking about hand washing. So identifying patient safety risks. So we've talked about falls. Hold on one second. Trying to. But they're also, they look for the, again, about the risk of suicide and minimizing those risks. So in the behavioral health area, things like, and they talked about removing door hinges that could be used for a patient to hang themselves. They're looking at the evaluation and treatment of clients in the behavioral health area. And part of the admission process and questions in the hospital often contain assessing the client for suicide, and and also domestic violence. Have any of you seen that in the hospital? I don't know whether or not you've been able to be with a client when they're admitted, or maybe a family member or yourself, where they've asked if the client is maybe safe at home, those kinds of things. They do it in the ER, but I've also done it on the floor when I've admitted, I'm going to say, a regular patient. Okay. Because they want to look at all patients. Thank you. Okay. So we're going to talk about in the OR again in the application. So we want the right surgery, the right patient, and the right body part. Y'all have heard horror stories about the wrong leg being amputated or something like that. So there is a pre-procedure verification, site marking, and timeout. So they're marking the surgical site in the perioperative area and procedure settings, and it involves the client, or as needed, the family. The Joint Commission doesn't specifically state that it's the provider to mark it, but they say it should be the individual who knows the most about the patient should mark the site. I've seen the provider do it in combination with the client. I did hear, I don't know if you've heard the story, but they had a client mark their surgical site. I'm going to say it was their abdomen. Well, it was a teenager, and she was bored because they marked the site and then they left her alone. So then she continued to mark the rest of her body, and she put little like jokes all over her body. So when it was like, not this one, and you're too high, don't look here, those kinds of things. And apparently they were like rolling in the OR the entire time. When a site is marked, it needs to be visible after the skin prep and draping. Okay, so it doesn't really help if you mark it and then you can't see the marking. Also, you need to make sure that the verification is consistent with, and the procedure is consistent with the client's expectations. And some of that goes with, think about the consent that the client is having or signs, right? So the provider explains the procedure, the client has the opportunity to ask questions, and the client should understand what's going to occur. I've also seen it in the outpatient settings where they'll say to the client, what are you here for? And it's a colonoscopy or an x-ray, those kinds of things. And again, timeout, and I know you talked about it in the OR, but nothing is supposed to happen. Everyone stops during the timeout and verifies that it's the right client, the right surgery, the right body part. And you'll see that in OB when a circumcision is done. Have any of you been able to see a circumcision yet? I know your time in OB has not happened yet for many of you. No. Oh. They said it wasn't allowed to see a circumcision? Oh, okay. All right. So we're going to talk a little bit about CUSIN in combination with JCAHO with hand hygiene. So CUSIN talks about knowledge, skills, and attitudes. So for all of the things that we do, it should be evidence based. We should have the knowledge to do the policy, the procedure, right? We need to have the skills and we need to have the attitude. So I'll go back to hand washing. You know how to wash your hands. We've covered it in class and we've done verifications and those kinds of things. But it's up to you to have the attitude that it's important. Think about Foley catheter. No one's watching you for so many of the things that we do, right? So we have to have the attitude, skills, and knowledge to be able to complete, say, a Foley catheter with the utmost sterility, maintaining that sterile technique so that we're not harming the patient. So CUSIN again talks about the knowledge, skills, and attitude, and they also look at safety. And so some of these things are very similar, where we're verifying the patient's name, date of birth, allergy, looking at those ID bands, the photo if we need to, right? Um, Side rails, which we've covered since last semester, the bed in low position, making sure that you're turning around before you leave the patient's room to make sure that the bed is low, the call light is in place, and the client knows when you're going to return. Hourly rounding has been incredibly powerful in decreasing falls, increasing patient satisfaction, and getting the needs of the patients met in a timely manner, be it a cup of water or pain medication. Falls are incredibly important. Equipment in relation to having proper equipment, properly functioning, and also decreasing falls. Educating ourselves, our clients, and you, because you are important. Oh, another slide the same. Never mind. So this is an example of an audit that may be done. And this was something by the World Health Organization, right? And so you may see, again, somebody from your hospital, you may see the Joint Commission doing assessing compliance with a number of things, and one of which is hand hygiene. And they're looking at the total number of um, hand washing and opportunities, and they should match, obviously, right? There shouldn't be a deficit because that means that somebody didn't wash their hands that was supposed to, and that could endanger a client. And you could substitute this. There isn't so hand washing is soap and water. The rub is alcohol based. All right. So let's talk a couple minutes about another friend from the neighborhood. I know you're excited to meet more of our neighbors. So Lydia Ocampo, she's 69. She has mild dementia. She lives with her husband, Danilo, who's a retired pathologist, and Danilo is her sole caregiver. And they live in this house with really no help. Their family is in the Philippines, so um, they don't have other family in the area except a niece who's kind of far away and she's in school. They did have a son, Ernesto, who died in a car accident several years ago. And they live in this two-story home with a large garden and yard, and that keeps them busy. So Lydia is able to do gardening around the house, and so she's kind of in her bubble. So if Lydia comes to the hospital, how are we going to identify her if she can't verbalize her name and date of birth? We have a wristband, but we're supposed to be verifying that against something to make sure we want to make sure that that wristband is on the right patient. So I see a couple of things. One is a photo. So hopefully that there's a photo, and especially if her husband isn't there. But if her husband is there, we can ask him. Okay. So we want to be careful. We don't an interpreter if needed, but I'm not anticipating an interpreter is needed. We but so you want to be careful about how we're asking the husband. So what is your wife's name? Instead of saying, is this Lydia Ocampo? Imagine it's not the story for this family, but he's as confused as she is. And I'm sure some of you have seen clients that say yes to everything. So you want to really be careful that you're asking open-ended questions and to be able to elicit the true response that we're looking for. Okay, hold on one second. Okay, so there was a dilemma. So um, Lydia had urinary frequency, and she had also a UTI, and she got up to go to the bathroom, and she slipped and fell in urine, and she broke her hip. So imagine you have a client with some dementia who is now in a new place with sounds, smells, and people doing things to her that she doesn't understand, and she becomes combative. And think about, we've already talked about the noise and alarms, and even just a pump that's beeping because maybe she's bending her elbow and it's her in her anti-cube, those kinds of things. Doesn't like the IV. Not very many people do like the IVs. So she's trying to remove them. She's got a large object between her legs, an immobilizer. And again, strangers are coming into her room and doing things to her. And so she's fighting them because she doesn't understand. When her husband's not there, she's in restraints because the nurses are trying to protect the surgery site, the IV site, those kinds of things. She's crying when he's not there. She refuses to eat unless her husband is there because she thinks these strangers are trying to poison her. What do you think some of the consequences of all of this is, might be, might lend itself to, turn towards? Delirium, delay in treatment, caregiver burnout, and that is a continuation of this story for this family is caregiver burnout. And think about discharge planning that we're going to do for this client. Is she safe to go home now? Malnutrition. I would also suggest dehydration, fluid imbalance, acid base balance, wound healing. I would also suggest wound infection, which then could lengthen her stay, requiring IV antibiotics and dressing changes. So now she's in a big kettle, a big mess. Also, skin breakdown, not just her incision, but also if she's in restraints, think about the ability to change her position. And yeah, a UTI, because if she's dehydrated, if she doesn't have enough fluid, then you've got stasis of urine and she's prone to a UTI. Pressure ulcer, depression, maybe. So just think about all of the different things related to this client that could have occurred, and how do we reverse them or prevent them? And there should be many different things that we can do to enhance Lydia's safety, which would be very individualized for this patient. Um, you know, having her husband there as much as possible, but we want to be careful with him too that he doesn't get too fatigued. And somebody had written in here that they hadn't thought about him being confused. And many times I've seen clients in the hospital that the two do well because of the strengths of the two. And it's kind of like a a three quarters and a three quarters makes a one, where maybe you have somebody confused, but um, they're able to meet the other person's needs, kind of thing. Um, and the challenge is, what if it was Danilo who was in the hospital? And then what would happen to Lydia? Because he's her primary caregiver. He's the one who knows her the best. He's the one who's able to redirect her, keep her on task, those kinds of things. And that's one of the problems that I've seen in the hospital when you have the higher functioning, the person who's holding things together, that's the person who's hospitalized. Okay, everybody. Any questions for me about today's content? Feel free to send me an email. Professor Chalal will be here, I believe, at 10:30. Let me just check my text message. Yes, she will be here at 10:30. All right. We're going to put a safety vest in your uniform requirements for next year. Just saying. On slide 17. So, Sonia, what it means is they look at the total number of opportunities that for hand washing. So every time the nurse goes into the room, for example, and out of the room, those would be two opportunities. And then they're looking at how many times either sanitizer or hand washing occurred, and they should be the same. Okay. You're welcome. All right, time to go get coffee.
Good morning, everyone.
Good morning.
Good
Hi,
morning.
good morning. I just wanted to make sure, first of all, as usual, you are able to hear me. You are able to see the slides. Okay, perfect, perfect. And so you're done with the safety lecture. I hope you got some break. I'm not sure until what time you have break. Uh, did they give you some time? You did. Okay. All right. Perfect, perfect. All right, so we'll begin with our today's lecture. One more minute. Okay, all right. So we'll wait like a couple minutes and then I'll start. Maybe students are still getting back. And after this 1 hour session, then you will have the exam review. I'm sure you know about it. They told you. So right at 11:30, we have 1 hour for delegation, and then 11:30 will begin the exam review. And that's necessarily we're going to talk about the concepts that we used in the questions. All right, guys. So I think we should begin now with our session. Um, Today's topic is delegation, which is a relatively easier topic to understand. Um, it's not as complicated as immunity, infection, or fluid electrolyte, or it's a relatively easier one. And since you are already in working in clinical rotations, and some of you uh, yeah, and no, I'm okay. And you already probably know a little bit about delegation and a little bit about the roles and responsibilities of different healthcare team members. Um, so we'll begin, but some of the terminologies will be new, and some of the the delegation process, and some of the things are going to be new. And just to give you a background on your reading, this delegation is from your module 39 in volume 2. So you are going to go through the PowerPoint in preparation for the exam when you're doing your study. So you're going to go through the PowerPoint and you're going to do the reading from the book. It's about 8 to 9 pages, and it's 39 exemplar C. Along with that, I just want to make sure that I tell you that I put the answers to the clinical examples. So there are some of case studies and reflect activities in the at the end of the module. So I have put all the answers in Word document in the post class activities. So you're gonna do that as well. And in the post class activities, there is also some NCLEX questions and dynamic module that you've been doing it. And we don't have any way to split the questions from different exemplars. So the questions are going to be all together from the whole module 39. So you really have to see which questions are related to delegation only, and you're gonna solve those. That will be helpful to you in preparation for the exam as well. Those are good, and the activities, the clinical examples and the reflect activities, those are good as well. So just to give you a little background on how to study for this topic. And for NCLEX purposes as well, this is an important topic. Most of the times, the questions that I have seen are merged with other concept. For example, you have a concept of acid-base balance, you have a concept of fluid electrolyte imbalance, and they merge the delegation into those concepts, but they still ask you, like, how are you going to follow the delegation process, or which is the task you can really delegate to the LPN or to the other personnel. Okay, so let's begin with that. In this picture, it's showing you that, I don't know if I have a pointer again. Okay, and here, right? So if we do everything by ourselves, we are carrying a big load. And if we split, then it's helpful to us. So that's basically the funda of delegation. These are the objectives listed for this presentation, and this is the concept necessarily that you can use for delegation. So I don't know how you're going to utilize that in clinical rotation, but it's necessarily when you start working, because at this point you won't be delegating. But again, if you see an unstable patient, your patient stable gets unstable, and you see, or you witness a lot of delegation that's happening there. RN is delegating a lot of tasks. Maybe you can utilize this concept and you can work, through your concept-based care plan. So some of the definitions: delegation. It is the actual transfer of responsibility to the other person. Actual process is called delegation. Delegate is a person to whom we are giving the responsibility. Delegator is the person who is giving the responsibility. Delegate is person accepting the responsibility. Delegator is the person giving the responsibility. And assignment can be a little confusing concept. There is a lot of overlapping as well, but basically what is the difference is, for example, for a CNA or PCT, at the beginning of the shift, they have their assignment, right? You all know that, like, they have 10 patients or 11 patients, and they have to take vitals signs for them. They have to check daily weights for them. They have to check blood sugar for 5 to 6 patients. That is their assignment. Delegation is something that is not in their assignment, right? It's a different task that is not actually in their assignment. Having said that, they have to check sugar at 5:30 before dinner for their 5 to 6 patients. But if you need another blood sugar checking because the patient's condition is becoming unstable, say at 2 o'clock, you tell the PCT, would you please be able to check a blood sugar on this patient? That would be delegation and not an assignment, right? So that is a little difference here. Between assignment and delegation. What are the benefits of delegation? Delegation does come with a lot of benefits. We can split it into different types of benefits. To the delegator, to the person who is assigning the responsibility, it decreases our workload so that we can focus more on the critical thinking. We can focus more on the clinical judgment and designing a care plan and the intervention, all sorts of things, right? That's our benefit. What is the benefit to the delegate, to the person who is accepting the responsibility? To them, it is boosting their confidence. It is increasing their skill level. We are going to give them feedback at the end of the delegation process, is increasing their knowledge in that regard. So there are a lot of benefits to the delegate as well. And to the organization, you can imagine if we are working as a team and it is a very well organized system in which we are delegating, we are accepting the responsibility, the organization is gonna obviously work well. To the patient, it's all about the patient at the end. For the patient, it is better outcomes, better quality of care that they are going to get, right? So as a patient, if we are in the hospital, we really don't care who is providing the care or who is delegating, which works are, they don't see what's going on in the background. All they care about is when we go into the patient's room, we are very organized in all the work that we are doing, right? We are not like hodgepodge that loses our trust right away. To the patient. So these are some of the benefits. Guidelines for delegating. So here are some guidelines that I took from your book, which are really good. And these also are listed on ANA website. They are also listed in the Practice Act or NSCBN website. So there are various resources that we can utilize for this process. Basic guidelines are that you follow your state nursing practice act. That's the main thing whenever we talk about any liability, any accountability for us for delegating for PCTs. We always want to go through the nurse practice act, and delegate only the task for which you are responsible, right? You're not going to delegate anybody else's task. Some other nurse has a patient and they have something. You don't want to delegate that task to anyone, right? So you're responsible delegating only the task that you are assigned for. You're going to follow the delegation process. This is very important, and we are going to talk about it, right? Delegation process. This works just like a nursing process. And you must also utilize the critical thinking and professional judgment when delegating, right? And these are some of the general guidelines to follow. 5 rights. Just like medication administration, there are 5 rights of delegation, proper delegation, right? And in that, the first is right task. So you go into the patient's room, you assess that, okay, these are the things that I need right away for the patient. So you choose an appropriate task. For example, just to make it simple, vital signs. It is a right task. Right circumstance. What that means is that now at this point you are delegating that take vital signs of this patient, right? And but after 10 minutes the patient's condition starts to deteriorate, and you really think that now you should be the one who should go into the room and take the vital signs, right? And so the circumstances change now, right? The desired outcome is changed. So that's what that means, that we have to see if the circumstance is okay for delegation. Right person, you want to make sure that you are delegating to the right person. It's either LPN, LVN, or the assistant, the unlicensed assistive personnel. Right direction means the right communication, right? You're going to tell them each and everything that you want about the vital signs, about everything. People have different responsibilities. But having said that, we need to make sure that, for example, all the PCDs are not going to be the same, right? Some PCDs have 10 years of experience versus there is a lot of disturbance. I think somebody is unmuted. I would appreciate if you can please mute yourself. Um, so we have to make sure that we provide the right directions, the right instructions for the delegating task, right supervision, that even after delegating the task, there has to be right amount of supervision that we provide. If PCT is relatively new and they don't know how to empty a drain, right? So they need a little more supervision versus somebody who is like proficient and who is competent in doing this task. These are 5 rights of delegation. The next is I have listed some clarifications that you need to do before delegating the task, and this is necessarily which we have already talked about, or we are going to talk about in the nursing process as well. But these are very self-explanatory clarifications before delegation. Okay, to delegate or not to delegate, right? That can be sometimes a little confusing whether should I or should not. For example, vital signs, you all know that you can delegate vital signs, right? As long as the patient is stable and you think, you can evaluate the data later, you can delegate that. At any point, if you're not able to hear me or there's something wrong, please let me know, because it gets a bit tricky when it's virtual. And For example, empty the drain, right? Let's go with that. Patient came after surgery. There is a abdominal surgery, and there is 4 or 5 drains that needs to be emptied. Now you are thinking, should I delegate that or should I not delegate that? Let's do this process on this patient. Is the patient medically stable? If the patient you think is post-surgical, it's a serious surgery, patient is crashing, the heart rate is not good, blood pressure is going down, maybe patient is bleeding too much, and maybe there is a lot of blood in the drain, right? You're right there right then, so you want to make sure you do it by yourself, right? Although we can tell the PCT that you empty the drain and do not flush it, flush the the output that you get. And but still, if patient is very unstable, you are right there, so you want to do it by yourself, right? Is the task routine and safe? Does the task require scientific knowledge or technical skills, right? Technical skills is a bit tricky. The PCTs, they do have technical skills, but yes, about scientific knowledge, the evidence base and the critical thinking, clinical judgment, you want to make sure that you do all those tasks by yourself, right? Is the task suitable to delegate per facility? The delegate capable of performing the task, right? Again, the same thing. If there are LPNs in the facility where you're working, right? Not all the LPNs are going to be same. If there is someone who's relatively new, you want to make sure that although it is within their practice that they can do this, are they capable of doing that, right? So you want to make sure that you supervise, because at the end you are the one who is still accountable for the task. Delegation versus dumping, right? That even the name is explaining itself, that when we are delegating, we don't want to dump our assignment on someone else, right? We don't want to make any unfair assignment. If you are a charge nurse, you don't want to make any unfair assignment, right? And the basic rule that you can follow really in your work environment is that you shouldn't be just like sitting there at the nurse's station and maybe talking to someone and not like not work related, just like outside of your work responsibilities, and the other person, the PCT, is just running around, right? The whole time she didn't take a lunch break and she didn't have time to sit down and she has 15 patients. So that is basically the rule of thumb you can follow, that if you took a lunch break, the other people should also be able to take a lunch break, right? That is the basic rule that you can follow, because again, these definitions and this theoretical portion can be really tricky when you are in work environment and working on delegation. And so you want to make sure that it is fair to everyone, because today that person is busy, right? If you're not helping them out, tomorrow your assignment can be really busy, right? And you are not going to get any help, and that will start a vicious cycle of that negative work environment that we all want to really avoid, right? And at the end, who is going to suffer if there is a negative work environment, right? Yes, you are going to suffer as well. Patients, at the end, patients are the one who are going to suffer from our conflicts, from our work issues, and that is really, really not good. I am teaching one other course as well this semester that has to do like with a little bit leadership and conflicts at workplace and the transition. And in that, that's basically what we are talking about, is when there is conflicts at the workplace, right? The patients suffer. And in that, one tip and trick that I can give you from years of experience is to avoid these negative things, to avoid these conflicts, you divert all of your energy to the patient, right? So you just, I always say, make yourself knowledgeable, learn about what patient is going through, learn about the physical condition that patient has, the test and the lab work and everything, right? When people see that your priority at a workplace is patient and the family, right, they will start to realize that, okay, it's not good to talk about any like minor issues and workplace conflicts with this person, because he or she is really concerned about the patient and they have high work ethics, right? And that I can definitely tell you from personal experience that this is the best way that you can use to get yourself or keep yourself at distance from all these minor issues. I mean, if there's a big conflict at the workplace, obviously you have to get involved into all that. And But when people see that your work ethics are really good and all you care about is your patients and to take proper care, to use evidence-based practice, slowly they will start to not talk to you about these issues. And whenever you delegate any task, people will take it seriously because they will know that you are doing your best to take proper care of the patient, right? But when the other people are going to see that you are not, worried about the patient and their family, and you are not doing your task properly, obviously the delegate is not going to take your delegation seriously as well. And hope that makes sense. So the next is the actual delegation process. This has 4 steps. It works just like the nursing process. The steps are a little bit different. Okay, so we are going to talk about it, and I can already tell you that this is a very, very important concept. Okay, I have seen questions on NCLEX as well on this, in which they would ask you, okay, you have done this step, what is the next step that you're going to do? Okay, you communicated, for example, you communicated the importance of delegation. What is the next thing that you want to do? You are not going to jump to the evaluation. No, you are going to jump to the supervision or surveillance. Okay, that's why it's very important to pay attention in the lectures, right? Because we do talk about important concepts. So delegation. So let's learn about the actual process of it. The first is evaluate. Not evaluation, assessment and planning, right? So in assessment and planning is, in all practicality, what you are trying to do when you are doing all these things is you go into the patient's room or you open up patient's chart and you assess what is your responsibility, what are the tasks that need to be done, what is the tasks that I can give to the UAP. Okay, I want to make sure we all understand the different terms that I'm using here. First of all, we are going to be like when you start working, you're going to be RN, right? Registered nurse. Then there is LPN, or sometimes they are called LVN. Those are licensed practical nurses or licensed vocational nurses, right? LPN and LVN. So what they are, probably you already know about it, but just for review, they do like 1.5 year around program, I think, or a 1 year program. And then they can it's mostly, I have seen in the rehab centers, a lot of LPNs are there, and there are some restrictions at their work responsibilities. Again, you have to go through the Practice Act, but they cannot assess the patient in an unstable condition, right? They cannot do the IV medications, they cannot do the cardiac chart list of each of the nurses do. Okay, yeah. And okay, I'm so sorry, Nicole. I take my words back. Okay, sometimes we have to choose our words wisely, which I obviously did not. I this was from my personal experience that I worked at a rehab center when I started my bedside career. So there were a lot of LPNs there, which were amazing, right? They had years of work experience, and I learned personally. I learned a lot, right? And but as Nicole mentioned, and thank you for that, that in the hospitals as well, there are LPNs and they can do IV medications, but not the IV push medication. So as Sonia is asking, is there a list? It is very difficult to give you an exhaustive list of the work responsibilities. Why? It's going to be different state to state. It's going to be different facility to facility, right? Where I was working, they were not allowed to do the IV pushes, right? So it's obviously, IV medication. So it's obviously different, as Nicole is mentioning. So that is the reason we cannot provide you an exhaustive list of the medications, right? You can go on the various websites if you really want to know about it. But is it difficult to know that? No, it is not, because wherever you start to work in your orientation period, in first 3 months or 4 months orientation that you will get, you will know about work responsibilities. Just to give you a perfect example, in Denbury Hospital, the PCDs do not do blood draw, right? In Yale Hospital, at the unit when I was working, the PCDs were all medical assistants, and they were allowed to do the blood draws. They were all also certified as phlebotomist. So we did not have any other phlebotomist. In the morning, all the PCDs, that was their work responsibility or their part of their assignment, that they had to do all the blood draws, right? So that is just to give you a perfect example why we cannot give you an exhaustive list, because it's going to be different from workplace. Having said that, are we going to ask you questions that are really tricky in that sense, like whether they can do blood draw? No, we are not going to ask you, because it's going to be different from facility to facility, right? For example, as Nicole mentioned, for IV medications, we are not going to ask you whether LPN can do IV meds or not, right? Because this is tricky. It's different from state to state. It's different from facility to facility. What we are going to ask you is whether you're able to apply your critical thinking in in the patient with an unstable condition. Which tasks can you really delegate, which apply pretty much all over, that we know for sure that you cannot do it, right? So that kind of, so these tricky things we are not going to apply. Okay, so in assessment and planning, so these are some of the questions that you want to ask, right? Is the task within scope of nursing practice? Did you assess the patient thoroughly? Is the delegating nurse competent to make decision, or the delegate competent to perform the task that you're going to delegate? If the delegate needs supervision, is it available? So that's sort of assessment, right? So that is the first step of a delegation process. The second step of delegation process is communication. Again, a very important step, right? So after assessing and planning, then you are going to communicate to the delegate what is the task that I want you to do, what are the responsibilities with that, what are the outcomes that we are looking for, right? And that what is the type of supervision that you have. So these types, so you have to do good communication, right? And the nurses must be available for any questions and feedback after delegating. So the first step is assessment and planning. The second step would be communicating, right? Very important. Third step would obviously be supervision or surveillance, right? So again, having made it step by step, it just makes it easier for you to follow it when you're actually delegating the task in actual setting, right? So now that once you keep that in mind, so you will never forget that, okay, it's still my responsibility to supervise, right? Because it was in the delegation process. So sometimes as students, you might think that, oh, this is all theory and nobody's following that in practice. For example, the nursing process, right? I want to stress this point that we are still following the whole process. For medication administration, all the nurses are still following the 3 rights and the 5 R's, right? 5 rights. But it is just so fast that you may not be able to process it when you see the nurses doing it, right? I was giving example to my clinical group that instead of a medication check 3 times, probably I do 5 times as a nurse. Honestly, if anything, it is more than less, right? But it's not like we are not doing the med checks and following the procedure. So even delegation, we do follow the procedure, right? So in supervision, it's really like, when after communicating, we want to make sure that we provide the necessary assistance to the delegate if they need it. Too much or too little surveillance, both are not good, as you can imagine, right? And we are going to talk a little bit more about that in the next slides. The last step of the delegation process is evaluation and feedback. At the end of it and the delegation process, this is very, very important. For example, they empty the surgical drain. There is a JP drain and patient had a back surgery, and you delegate the task, right? After they empty that, if they did not do it right, for example, some of you may already know that JP drain is called the bulb suction. And for the bulb suction, we have to squeeze it at the end, right? I'm just giving you an example. We have to squeeze it at the end so that it is in a working position. So if you did not supervise it, that's a problem, right? So now they did not do it right, right? So you don't have to be there the whole time, but whenever you go into the patient's room, say for medication, your hourly check or something, you need to make sure that you are still accountable for that, and you take a quick look at the JP drain. Okay, is it squeezed? Is it in working condition? And in your evaluation and feedback, now you're going to tell the delegate, right? The basic thing. You're going to tell them that, this was what was supposed to be done and you did not do it. Make sure in future you always do it, right? And but now in future, if they keep on making the same mistake, that is a problem. As you all know, now you are the in charge right there, and you really have to intervene. Right now there is a question of competence, right? Following the direction. Now there is a question of that, and you have to work as a team. Having said that, it's all about patience, right? So now if you see one of the team members is not competent after 10 times of directing, they are still making the same mistake, you have to escalate things to your manager, right? So that sort of thing. Give praise and recognition for a job well done, right? Cannot stress it enough. We all need it, right? You as students need it. We as instructors need it, right? And our team members need it. So please, please make it a habit. It's going to make your work environment really positive when you get into the habit of, we have to encourage each other, right? Rather than pulling each other's leg as a team member when we are working, especially it's related to this concept of delegation. We need to encourage each other, right? If somebody's confidence when you're in a conference, right, and somebody is not able to speak up and about their patients they are telling, and it's an interdisciplinary conference going on, instead of I don't know, you have to encourage the person, right? If they are stuck at some point, oh yeah, this is what you mean to say, I think, right? Yeah, patient is getting LASIK. Oh, are you talking about that patient? So that sort of stuff, right? We as nurses, we need to encourage each other more. And so that is basic fund of giving praise and recognition for a job well done. Cultural considerations. So for this, it's 100% sure that when you start working as a nurse, there is going to be people in your healthcare team who are going to be from different backgrounds, different culture, different language, right? Because our diversity is increasing, as you all know. So it is for sure that you will be working with people from different backgrounds, right? So in that, now you have to be mindful when you are delegating the tasks. There are some other things that you need to consider, right? So first among them is the communication, right? So the healthcare team members, the language is gonna be same, not the primary language, but they are gonna know English, right? And because we obviously, if like they don't know English not very well, but like if they don't understand at all, and that is a problem. So when they hire people in the organization, they want to make sure that we have a common language of communication, right? That is the first thing. That is, again, it's nothing that the people who don't speak English, they are not knowledgeable about the job. It's just that for quality patient care, for safe patient care, we need to have a common language, right? That's the basic thing. Okay, we need to understand English, and we need to at least be able to communicate our ideas, right? Culture, which took me a bit to figure out, right? Sandy is sharing her experience with it, and thank you so much for sharing that she did work with someone who had different culture, and it took her a little bit more time to really understand their culture and really be able to give instructions in that sense. So first is communication, right? Some people really like you to give extensive instructions, right? Okay, this needs to be done, and this is how we're gonna do it. Yeah, and then some people are like you tell them once, and they are okay with that, right? So this is something that we are gonna learn over time, in your orientation. I'm pretty sure if you're going to be working on one unit, in 3-4 months, you can kind of get an idea of everyone working there, right? A basic idea at least. Okay, this is how these people work, and this is their style, this is their language, and this is their kind of little bit background. So you can like modify yourself according to them, and they are going to modify according to you, obviously. And space, space is a bit tricky term. In this is some people really like to get involved with you. They want to sit down with you, they want to know each and everything at the beginning of the shift. They really like you to be able to again collaborate with you. And some people, they maintain a little bit space, right? You just call them once and you tell them, okay, this is your assignment, this is what you got to do, and this is the task that I'm going to delegate to you. They're okay with that. Social organization, this basically, I have to a little bit help with that. Okay, so no, this is social support. Actually, I should have put the /support. So this is basically how much social support the person needs, right? Some people need you to be there, initially in the beginning, the whole time. And so you can write it. It's necessarily social support that they need. And time. Some people need this is really like a short-term goal or long-term goals, right? Some people, you tell them, okay, this is the task right away in 10 minutes that you have to do, right? For some people, you can tell them the whole day schedule and they'll be okay with that, right? And this, again, it is related to the culture as well. But even in general, you can think that people have different personalities, right? Some people like to plan ahead. Some people just go with the flow, right? So basically, time is short-term or long-term goals, and it also can apply to the time that person needs to complete the task. Then is environmental control. In environmental control, this is necessarily some people are very proactive. They like to take the whole situation in their control. What that means is they plan ahead. Okay, I have 5 blood sugars, I have 6 vitals, I have 1 shower, I have 3 bed baths, and they like to proactively plan ahead. Some people, not maybe very organized, right? They just go with the flow. Okay, it's 5 o'clock. Okay, it's time for sugar. Let me see how many patients do I have for blood sugar, right? Now, as an RN or as a person who is delegating the task, you're not going to be annoyed at different personalities or different work. Uh, um, Different types of work that they do. If they are proactively doing it, it's fine. As long as the work is getting done, that's my whole point. As long as the work is getting done efficiently, competently, patients are satisfied, you should be okay with that, right? If now the work is not getting done, right? The patient care is not properly getting done. The routine hygiene care is not getting done. Then you have to step up. Biological variations. For some people in the countries in which, for example, tuberculosis is prevalent, HIV is prevalent, they might have their own stereotypes with that, or sometimes they even be biologically more prone to some type of infections. So these are the biological variations that are there, right? If they're biologically prone to some infections, that's a different discussion, right? But if there are stereotypes, if you see one colleague and they are repetitively avoiding like patient with tuberculosis or HIV, then you have to have a conversation with that person, right? And about their stereotypes. I put this picture here. I don't know if I have used this in the past. Do you have any idea how is this picture related to the cultural considerations? Anyone? Soil? Yeah. You can you can unmute yourself as well.
I was just going to say, you're trying to foster some new growth and new development and create a culture that's, positive to everybody. So it's kind of taking care of a small plant from the bottom up.
Bottom up. Yes, absolutely. Thank you so much for that. And all of you who wrote in the chat, thank you so much. Yeah, you guys are right as well. So basically, the seed is the same. I should have probably another picture as well. The seed, it's encouraging each other as well. And along with that, the seed is the same. It depends how the soil is. It depends if the soil is fertile or not. It depends if they get the water, if they get the food, if they get the nutrients, then only they are going to flourish. Right? So people from different background, different culture, different language, right? The seed is the same. They have as much capability as we have. Maybe they did not get the proper resources, right? So now they started their job as PCT. We don't know how many struggles they have done in the past, right? To get to that level. For them, it's an accomplishment that, okay, they did their CNA course and they passed their test and now they are working in the hospital, right? Now, if they don't get a positive work environment, they are not going to flourish, right? So we have to be that water, we have to be that nutrient, we have to be that soil, right? That can help them flourish. So that's my whole point. Okay, and that is the obstacles for delegation. So there are, different types of obstacles for delegator, the person who is delegating the responsibility. Maybe we are like scared. We are scared for the liability, accountability, right? That's why that is a big obstacle. And for the delegate who is accepting the responsibility, again, they are not scared. They are scared to accept the responsibility. Sometimes even overconfidence, that can be a problem as well, right? They think that, okay, they can administer medications. A patient is unstable and they think that they can walk the patient. There is a drain. They think they can empty it when the patient is unstable. And personally, I am more scared of overconfidence and then underconfidence. Okay. Even for I think you should be as well when you start working, because even as students, if in the it's only second semester, beginning of second semester in clinical rotation, sometimes you might be a little hesitant to go into the patient room assessing and giving medication. That's totally understandable, right? We are there to help you, to support you. So we are there to boost your confidence. But if you're overconfident, now you think you can do everything, that's what scares me, right? And the third thing is environmental related. That's basically to see like there is not proper resources, financial constraints, there are not enough people, there's only one vital sign machine when you want to delegate the tasks. That's some of the things. Quick quiz. What is the role of the nurse manager in ensuring that the proper delegation is being utilized in the unit? So the nurse manager also has a big role to play. Okay, so very important concept that what are they gonna do? Communication. Yes, thank you so much. And that's a big thing. For example, the nurse manager, important concept, right? I want you to pay attention that a nurse manager, when they witness that nurse is over delegating the task or under delegating the task, then they have to intervene, right? And they have to intervene directly to the nurse who is giving that. They are not going to generalize on the whole floor or whatever. So they have to go to the specific nurse that this is the issue, this is the task you are delegating, and is it right, is it not right? And they have to communicate. And even in the beginning, they need to make sure that they talk a little bit about delegation as a unit as well, right? That was also, create a good environment. Yes, surveillance and feedback. So surveillance and feedback evaluation, that would be specifically, I want to say it would be more to the delegator and delegate. That is going to be a delegation process that's going to happen between them. For a nurse manager, they are not going to be responsible for supervising that specific task. But yes, you're right that they are going to be overall responsible for supervising if the delegation process between all the employees is going well. Oh, that makes sense, right? So they are not going to be for one specific task, but overall they are going to provide their feedback. They are going to supervise that the process is going right. But if there is any issue, they are going to intervene specifically to that nurse first, right? And then they can, in services or in the conferences or they can tell as a group as well, okay, this was the problem. But first, if there is an issue with a one specific RN over delegating, under delegating, manager must talk to that nurse, okay? And ineffective delegation. These are again some of the terminologies that I have there. The first is the unnecessary delegation, unnecessary duplication. I tell somebody to take vital signs and I go there, I take vital signs as well, right? Now it's total wastage of time and resources. Under delegation, right? These are important terminologies. Under delegation would be, sorry, Stephanie, your hand is raised up. Do you have a question?
No, that was from my previous comment about the plant. Sorry, it stays lit for some
Oh,
reason.
okay.
Yeah.
No problem. No issue. And under delegation. So under delegation would be, yes, just a second. I'm going to finish that, then I'm going to come to that question. Under delegation is that for the vital signs, right? I tell somebody to take the vital signs. I go there, I take respiratory rate, or I take the heart rate by myself, right? If you do that, you let the other person know that I already checked their heart rate, I already checked the respiratory rate, so that they don't waste their crucial 5 minutes or so doing the same thing. This is under delegation. Reverse delegation, as you can think about it, it's like if an unassisted UAP or the PCT, that's delegating the tasks to the RN, right? That is not going to happen. What they can do is they can ask you to help out, right? Obviously, they have all the right to say, I am really busy. Would you be able to check the vital signs for this and this patient? But that is not delegating a task, right? And but this is called reverse delegation. You can assist them. That's the whole, but just the terminology is not right. That's all I'm gonna say. Over delegation is now dumping, that you're giving just too much and they are not even like responsible or authorized to do that, and you're doing that. So some of the very simple terminologies here. Liability and delegation. I understand that you might have fear of your legal things, what comes with that. I can assure you that once you start working as an RN, during your orientation period, you will have a very, very clear understanding of what other people can do, right? You don't have, it's your choice. You can go to Nurses Practice Act, and I have read that, and it's a long pages of nurses responsibility, LPN, and PCDs. It's good to once go through that. They have listed the responsibilities of providers, APRN, nurse practitioners, everybody basically. So you can go through that. And these are two other websites. I don't have the direct links, but I can share with you. They also have provided us guidelines, but most of their guidelines, we have put that in PowerPoint and it's in your book. So most of the guidelines are there. For example, this NSCBN, I have put in the pre-class activities for you. The whole paper they have about delegation, I did put that, and they basically shared the same information that I have in the PowerPoint, but you can go through that. But these are the, basically it's the state Connecticut Nurses Practice Act that we have to go with. That is the umbrella thing that we have to go with that. Other organizations are just providing their own guidelines for delegation. Okay, some of the tasks, it's all from your book. Can you delegate these tasks? These are vital signs, INOs, transfers, postmortem care, packing the body and helping with that, bathing, feeding, attending to the safety, making sure that patient is safe, they don't fall, putting the bed alarm on, putting the side rails up, and weighing the patient. Can RN delegate these to unlicensed assistive personnel? Yes, very easy, right? Very easy. So these are, again, it's not the complete list, but these are the general, I want to say the responsibilities that they can ask you, because they are not going to ask you tricky questions in which different states have different rules, right? In NCLEX or even exam, it applies to both, okay? So you don't have to worry about that. So, but generally all these things can be delegated. The next one is, oh, yes, can be delegated. And the next is, can RN delegate these tasks? Okay, right? You have to now pay attention. Assessment of the patient. You already know the answer, I know. Assessment of the patient, right? Head to toe, focused, interpreting the data. Now, lab values, right? And making a nursing diagnosis. Yeah, thank you, guys. Yeah, no. And making a nursing diagnosis. Creating a nursing care plan, evaluating care effectiveness, IV line, NG tube, administering medication, patient education, simple things, they can educate the patient, but it's our responsibility, right? Patient education, administering oxygen. So these are the tasks that we cannot delegate, right? It's your responsibility. It involves critical thinking, clinical judgment, and all that. Let's do a quick case study. For like to get our thinking started, how to, now in some places I have heard LPNs can go do NG tube medications. Sonia, I am not sure about that, honestly. I can maybe find out a little bit more if they can do it, delegate. Reinforcement of knowledge. Yes, you can definitely delegate. If we have done the patient education completely, thoroughly, and we can delegate. Not about medication. I would not delegate LPN. You can. I would not delegate to the PCT to reinforce education on insulin administration, right? Or even medication, the oral medication administration. I can delegate them about after back surgery. Okay, what are the limitations they have to follow, right? In the feedback evaluation, we talk to the PCDs. They want to get more knowledgeable about what they're working with, and so we can tell them to reinforce the education, right? And but not the critical things that we don't want to. Why? Because there can be a discrepancy between the information that they will share that we have shared. So I would not delegate a lot of patient education to them. Very, very simple things about diet or something. You can tell them, like, your patient has diabetes, okay, you can eat a lot of fats and carbs. Everybody knows that. So yeah, that kind of stuff. For exam purposes, if you see question about NG and IV med, should you delegate? No. For now, you say no for the IV and NG, okay? But as it's a bit tricky, as I mentioned, we are not going to ask you that. Again, if there is one answer to that, I will definitely make sure that I ask the other faculty members, or I do my little research. If I can find a single answer to the NG tube and IV medication, I will put that in announcements or somewhere, right? I'll let you know, but you're not going to see any question related to that on exam, I can tell you that. And so you are working the night shift on a medical unit and have been assigned charge nurse responsibilities. You are working with, now there is 4 RNs on the unit. Okay, I want you to visualize this thing. This is the last thing that we have. Okay, after that we'll start the exam review. Dr. Murphy is coming back at 11:30 to do the review first, and then I'll do it. And so on a medical unit, there you have 4 RNs, you have 1 LPN and 1 PCT, right? Assistive personnel. A patient becomes pulseless. Now patient is coding, right? And you are the nurse of that patient, and you are there for 1.5 hours to resuscitate the patient. 2 other nurses are with you assisting. Here I wrote that 2 other nurses are assisting with you in the code. Now on the unit you have maybe 15 other patients, and you have 1 RN that's available there, because there is 4. 3 are stuck in the for the resuscitation. So 1 is there, 1 LPN is there, and 1 UAP is there, right? So you can unmute yourself as well. How are you going to kind of handle this situation for delegation? What are some of the things that you're going to do? Anything. There is no right and wrong answer for that, right?
Evaluate what needs to be done. Rounds on your other patients, and the LPN can help with that as long as they're stable.
Okay, so vital signs on the other patients. So yeah, and you can type as well. Either way is done. So you're gonna tell the LPN or the UAP to do vitals on other patient. Perfect. I would send other LPN and CNAs to make sure other patients are stable ABC, right? So both the answers are right. So so you're going to tell them their airway, breathing, circulation is still good. Again, CNAs cannot do the full ABC assessment, as you know, but they can take vital signs, right? If patient is breathing is not right, or something they see that's wrong, they can take vital signs. Ask RN, administer. Yes, the other 2 RNs that are assisting you in the code, you're going to ask them to administer the medication according to the team leader instructions, right? In the code, there is a team leader and there is other members as well. make sure they're getting meds around the clock, nothing is missed. Okay, that's important as well, right? So other RN, so now we are gonna shift our gear to just a functional level of working, in which we are not going to worry about for that hour and a half that we have to do everything on time for all other patients, right? Now we are going to take a step back, because right at that time, our responsibility is to just focus on resuscitating the patient, right? And the other patients, as Sonia mentioned, that we are just going to make sure that we are giving them the medications, right, one by one. Again, there's only one RN, one LPN. They are giving medications one by one, and they're making sure that they are stable. That's all we're going to do. Assign someone appropriate equipment for the code. Thank you. Yeah, right. So you're going to tell one of the PCT that's there to get the crash card. That's called crash card, which we use in the code blow, right? So just to get your thinking started, this was a little exercise. That's what we're gonna do. But in this situation, when there is any patient who is unstable, who is coding, who you have to call a rapid response team, the one thing that you need to make sure is that you are right away gonna start focusing on that patient and be with that patient, right? You are not going to leave that patient. All other patients, until so as long as they are stable, right? You are not going to worry about their medications. You are not going to worry about, taking them to bathroom, or you're not going to worry about anything else, right? Right at that time, you need to be at the time they become unstable. You have to stay with the patient. You're not going to leave the patient. This is a very important concept, because I have seen a lot of time this happening actually in real scenario as well. You are giving report to the next nurse, right? And a family member comes, and the family member says, "Oh, my patient, I think he's not feeling right." And their breathing is not right, or just they say they are not feeling right. You are not going to continue with the report. As much as you're tired, as much as you really want to go home and get some rest, at that point you need to make sure that you stop giving the report and you go check the patient, right? And so this is the basic idea of delegation. And one other thing is, although it sounds very simple, the whole presentation on delegation, right? It was very quick. And but when you are in a real life situation, when you start working as an RN, these things get very tricky. Tricky in the sense, not that you don't know what the responsibilities of other person is. Chances are you're going to be well versed with what they can do, what you can do, especially when you are in your orientation and you start working, right? But the main thing is that, do you feel comfortable delegating the task? I have seen a lot of nurses overworking just because they are not ready to delegate the task, right? And or the other way around, dumping the assignment, right? So again, one tip and trick I already told you, I cannot enforce it enough, that if you are doing your job right and you are caring for the patient right, you are caring for the patient right, it should be okay to ask for help, and other people will start recognizing it, that okay, you are worried about the patient, and that's why you are asking for help, or you are delegating this task. I know it can be hard to ask for help, but we just need to get into the habit of that, right? And for that, your knowledge, your experience, your competence, your compassion, everything is going to come into play. When you slowly start to get all these virtues and slowly start to get competent in providing nursing care, you will also get competent and confident in delegating the task. And I can tell you for sure that this thing will come with time, right? Confidence is a big thing, but it only comes with knowledge and experience and competence, right? And you can fake it until you make it. Yes, we can, but for how long are we going to fake it? So we really need to start studying and open the literature, open your book and read the PowerPoint. This is all you can do at this level when you're a student, right? So there is no alternative to study, really, right? Yeah, so this is that. I think we're done. Again, our quote is which is perfect actually for this presentation. To be in charge is certainly not only to carry out the proper measures yourself, but to see that everyone else does so too. Right? They're perfect for delegation. And she said that 200 years back. Now you can think of like, how much visionary, Florence Nightingale was, that she said at that time that it's not just you who's doing the work right. You have to make sure everybody's doing their work right? Because after all, that's all, it's all for the patient. All right, guys. So this is all. And I open the session for any questions if you have. And in a couple minutes, Dr. Murphy is going to come and thank you. And yeah, there's a lot of good quotes and there's a lot of good readings from right now. I know you don't have time, but when you graduate and you have a little bit of, downtime, or in your break, you have downtime, just Google it. All the nurse scholars, nurse researchers that we have, and they have some great readings that, that we can find there. All right. And then we have the exam review at 11:30, but oh, thank you. And yeah, any questions you have from this or from anything? So it is the review of concept of the question. We are not going to do that because it's not